are now going to actually move on to the next session, which is on best practices for community models around hepatitis B and C. Our first presentation is actually going to be with Karen Kim, who will be doing on hepatitis B, and that's going to be followed by Pam DeCarlo, who will present on a successful model that's been done for hepatitis C with substance abusers in California, and they're going to share that with us. So Karen, do you want to come up?
Okay, I feel like I've been on this stage way too long, but since I'm on here, you have to listen to me. So what I wanted to do is talk about a program that is very, really near to my heart and also very important for the Asian Health Coalition. I think many of you in the room may be familiar with the Asian Health Coalition, but it's a nonprofit community-based organization that's really one of the only community-based organizations that focus solely on sort of pan-Asian health. And so unlike one specific ethnic group, we have really been able to look at multiple different communities, all through partnership with our community-based organizations, many who are here today. So I'm going to go ahead and start talking about this hepatitis education program kind of in the context of the state of Illinois. So if you think about Asian Americans in Illinois, we're the sixth largest concentration. We're the largest state in the Midwest. There's approximately 570,000 Asian Americans. What's very important, and we've heard about this morning, is that about 65% of all Asian Americans in Illinois are foreign-born, and with that comes, high risk of disease burden from your home country into the United States. About 33% speak English less than well, so this is the limited English proficient population that Dr. Kandula talked about. And there's really one safety net system for the entire state, and that safety net system, while it's very strong, has challenges in providing health services for those who have come from different cultures and certainly that speak different languages. I tend to think of things in a very simple way. So you heard a lot of data, but this is really what I look at when I think about the racial distribution and ethnic distribution of hepatitis B. Basically, if all of chronic hepatitis B in the United States was comprised of this circle, half of them would be in Asian Americans, kind of the yin-yang model for Asian versus non-Asian for hepatitis. The other thing that's really clear is how do we put these diseases on the map? And as you saw with Dr. An earlier today, he spoke about liver cancer not being one of the top cancers that we're seeing, but one of the top causes of cancer death. But I think this slide is really important. This slide looks at where we think we're going to be in 2030 if we just don't do anything different. And basically, this is looking at the total cancer incidence that is expected in the United States by 2030. And what may surprise you is where these numbers fall. So you can see, you can see the Caucasian population here at 31% by 2030, and as you go up, African American population, American Indian, multi-race Hispanic, the Asian population, which I've highlighted in red for you to see, and the Hispanic population. So you can see the newer immigrant populations, the Asian American and Hispanic, may surprise you that they are really the populations that if we don't do anything different are going to really be leading the cancer incidence by 2030. And so we know this now. We have about 20 years to make a difference and hopefully change these numbers. And in particular for the Asian community, we think that liver cancer is one of the cancers that are really going to be driving these statistics. And so I think that we have kind of a perfect storm to think about model programs to make differences in our community. And this perfect storm looks at sort of where we are, the state of viral hepatitis in Asian Americans in Illinois. And when I think about this, I think about the disproportionate burden of this disease. I already told you that particularly for hepatitis B, we think of those chronically infected, 50% are Asian American. We also know that rates of hepatitis C are probably highest in Asia, and with that, I told you earlier that 70% of Asian Americans tend to be foreign-born in Illinois. That means those diseases come across the ocean. We also think of viral hepatitis and actually liver cancer as being one of these, of liver cancer being an orphan cancer. It's not one on one of the top 10 lists, but it is the most rapidly growing cancer, cause of cancer death in the United States today. So as sad as that makes me, hear that number, a part of me is doing a happy dance because maybe we'll get on the map and this will not be such an orphan cancer, particularly with new drugs in the pipeline for hepatitis C, where we think we may have approach 100% cure, and a very, very effective hepatitis B vaccine that will allow us to prevent this disease going forward. We also have gaps in our healthcare system that add to the storm, particularly providing cultural and linguistically appropriate standards across the board. There's a paucity of data. Our surveillance system is really poorly funded despite the best of interest. There is an incredible lack of awareness when it comes to viral hepatitis, both for hepatitis B and hepatitis C. And the Institute of Medicine report, as Dr. Ward mentioned earlier, said that across the board, from students, communities, to leaders, to politicians, to policymakers, there's just a lack of awareness about the disease. About 65 to 75% of those who are infected don't know that they're infected. And often many physicians and healthcare systems don't make the process of collecting data easy. And again, as you saw, the one depressing slide that we saw this morning that Dr. Ward presented is really the paucity of funds to be able to make an impact on this disease. And that's why I think with this perfect storm, we thought of developing the Hepatitis Education and Prevention Program, which actually was developed in 1998 is when we started this. And this was actually by a very generous grant from the pharmaceutical companies, actually, to try to understand how to reach out to Asian American populations. And from that, we were able to start this program, and it has just continued to grow and build. The real purpose of the Hepatitis Education and Prevention Program, which we call HEP, is to build the infrastructure and capacity of Asian communities for hepatitis education and prevention. And while we really talk about not aggregating Asian communities into one lump sum, what's really unique about this program is our ability through our community partnerships and collaborations is to sort of look at hepatitis prevention in individual communities. And our communities that we started with were Korean, Chinese, the Lao community, the Cambodian, the Vietnamese community, and more recently we have worked with the Burmese community, South Asian community, as well as some of our African immigrant communities, particularly the Ethiopian communities. And what we have strived to do with this program is to provide ethnic-specific targeted outreach and health education using a community health worker model. So it's very clear that when, even despite your best intention, if you don't have the right people at the table delivering the message, then that message is often not heard. And that's particularly the case when you're going into Asian communities with a disease that may inhibit employment in some parts of the world, such as in China, as Esther Wong mentioned on the panel, that there are large populations who are disenfranchised based on their hepatitis B status in China. And if that population immigrates here, and we are, as physicians or actually even community organizations, go out and just tell people they need to be screened, that message isn't heard. And in order to help bridge that gap, we use our community health workers, who are individuals that are from the community, that are trained to be able to understand the problems and situation with viral hepatitis and translate that into a community, putting community context so those people who are living together with these community health educators can actually understand the significance. Our goal was also to increase hepatitis screening and immunization for the Asian population and to really provide appropriate linkage to care and patient navigation using our community-based partners and our community health workers. Often we also use students to help us with our linkage to care navigation. So this is really, our HEP program is really an example of a really wonderful partnership and collaboration between multiple sectors. Certainly, we would be nowhere without the community-based organizations and our community members. But certainly the academic institutions have also helped us when possible to provide evidence-based best practices and bring that into the mix. Our public health department, I know we have a whole bunch of students here from Chicago State University, and I would have to say that Dr. Arnold, your fearless leader, and Dr. Britt, but certainly Dr. Arnold, when he was the director of the Illinois Department of Public Health, ensured for 15 plus years, he continued our support and our funding to help with us with these programs. So he's really has been amazing. Our industry partners have also been able to provide a lot of support for screening, for immunization, which we would not be able to do with the really low level of funding that's often available for this program. And the National Cancer Institutes of Health has been very helpful in promoting these programs and providing some resources. And the CDC has been really instrumental in helping us come up with a dissemination plan and helping us with our model so it can be more sustainable. So one of the things that we have developed is a multi-pronged approach to understand how to do capacity building to perpetuate this program. At the community level, we have done organizational capacity, so we have worked with community-based organizations that have the capacity to help us reach our goals. We've also worked with community health workers who are identified through our community-based organizations that have worked with us. We've also did GIS mapping to understand where are our populations and where are the resources for the communities that we want to serve, and so there is some type of linkage mechanism. At the provider level, we have provided resources, including developing a bicultural physician directory to understand where those physicians who look like you and speak like you live, so we can refer patients to you, and also have done simultaneously a lot of provider education. So what's very clear to me is that understanding hepatitis B and C and being ignorant about the intricacies of this disease have nothing to do with your level of education. So even faculty, am I being taped? Okay, well then erase this part. But even faculty at the University of Chicago, and I shouldn't say even, but faculty at the University of Chicago and universities all over the country don't understand how to screen individuals for hepatitis B and C and are very confused about which populations are at risk. So I know when I went through my medical education, residency, and fellowship as a GI fellow, where I would think I would learn about this, it was really shocking to me to know that Asians were disproportionately affected by this disease. So I think that it's really important that we educate at the physician level as well. As Dr. Ward said, these tend to be the gatekeepers to adequate treatment and follow-up care. At academic institutions, we also really want to make sure that we understand guidelines for implementation for services and really to engage students who are our next generation of leaders that are going to make a difference. At the industry level, HEP has been involved in targeted messaging and helping cultural competency and message delivery for Asian populations. And in terms of capacity building at the public health departments, we really push them to understand access to care, patient navigation, and policies and reporting, because I think data needs to drive funding, and without funding, we really can just have a lot of lip service. This is an example of our Asian Health Coalition Physician Directory, which has physicians throughout Chicago and DuPage County who are bilingual, bicultural, and that are willing to see patients who are in need of culturally competent care. In terms of the community health worker, which is a really integral component of our HEP model, and this kind of shows you what we think about when we're thinking about this model for hepatitis prevention. So here you have issues that face the community, which I think many of us have spoken about, but certainly there's a positive knowledge and awareness. There are many cultural values and norms which we really need to understand. There's the fear of discrimination and stigma that can be associated with hepatitis. I know that there have been many different attempts to try to get awareness. I know that Janet Zola is here and is later going to be talking about their very successful Hep B-free model in San Francisco. But some of the scare tactics sometimes work and some of them don't. And I think that's really depending on the region that you live in and the populations that you're serving, how that may impact the ability to move an individual to get screening. There's also issues with the community about continuity of care. So you can start a program, you can be very excited about it, but how do you sustain it and implement it so it actually makes a difference? In terms of solutions that we think about being able to provide bicultural and culturally competent care. Our community health workers really bridge the gap for finding social support. They have shared values with the communities that we're trying to work with because they are from the community and they represent the community. And they really help us bridge the gaps between treatment, vaccination, tracking, and linkage to care. And this is a picture of actually quite an old picture of some of our community health workers when we first started our HEP program. And basically what we do with the community health workers is we provide education. I mean, we meet with the community health workers either once or twice a month to make sure that their education is up to par. They end up doing presentations in front of us in a very kind and non-judgmental way. So, and many of our community health workers are sitting in our audience, and they could probably stand here and tell you about our program much better than I can. But I think that it's really, really important that you recruit the right people who are really dedicated to trying to make sure that they can move their community. Once we've provided outreach with our trained community health workers, we then figure out who needs to be screened and get referred. And then many of these community health workers then help us bring and recruit individuals to our screening events, or to link up to the providers that were provided in their physician directory. Once we do a screening, we sort of understand which patients or which clients are at risk and therefore may need to be immunized, and we provide immunization. Which clients need to be, are okay because they are already immune. We kind of let them know to continue to follow up with their primary care physicians, and which clients are in need of treatment or further follow-up care. And that's where we have sort of a multi-pronged approach to those who are involved in our testing. And with our testing, we always ensure that there is some type of community education. Dr. An, who is here this morning, has provided a tremendous amount of sort of free services in terms of education for our communities. And again, so what are some of the roles during our screening events for our community health workers? Certainly, they refer community members in, they provide counseling, and they provide translation and interpretation when needed. This is a picture of one of our screening events in the Cambodian community, and some of our medical students were there with our community health workers. I was telling people who were at dinner with us last night that this is one of the Cambodian monks, and for some reason, our students who were just doing an amazing job with blood draws. As soon as they got to the people dressed like this, so the Cambodian monks, none of them could draw blood. So this poor guy got stuck about 15 times. And he was very nice and patient, but I was dying inside. But I realized that, the students were so nervous for some reason because of drawing blood on a monk that they really lost their skills. So we're always in a place where we need to do continuous training, cultural competency training, and understanding that everyone really is the same on the inside. But we could talk about this for a really long time, but I think that what's important is what are some of the metrics that we measure our success by. And this is looking at from 2006 to 2011. And this is looking at, I've highlighted in orange some of the key numbers that I thought would be important. And this is number of people educated in this last 5 years is about 32,000. The number of people who were referred for screening and immunization, about 17,500. And the number of adults screened specifically at our HEP events, about 2,100. And so what you see is that if any one organization were to try to do this, there's no way that you could have this type of capacity. And so coalition building and partnership is key to be able to sort of have a halo effect and spread out amongst our communities. Looking at some disaggregated data, this is looking at our 10-year experience with the absence of 2 years where we are still trying to figure out what happened to that data. This is looking at the Cambodian, Chinese, South Asian, Korean, Laos, Vietnamese, and Thailand communities in terms of hepatitis B surface antigen. So for those of you in the room who are not as familiar with that, this antigen is what we think about when we think about those who need follow-up care. They may be infected, they may have chronic hepatitis, and it's our marker for chronic disease. So you can see the percentage will vary if you're from Cambodia versus Vietnam versus China versus India versus Korea. Our percentages really, really are different. And so we do need to look at, kind of disaggregate the data in order to see differences and understand those behaviors and sort of what risk factors are available for these different populations. And to get back to what Dr. Kandula said is that you could spend a lot of time on messaging, but if you don't pilot it or have the community involved, you could really be in trouble. So we did a huge survey among these communities, and we were looking for risk factors for viral hepatitis. And one of the questions that we asked was IV drug abuse. Well, I didn't think it got translated right, but we said IV drugs. And what we found was that most Asian women have IV drugs. And what we thought was that was really unusual. Why are all of these drug addicts, why are we having all these Asian women drug addicts? And it turns out that we asked the wrong question. In fact, many women interpreted that question as if you're having a baby and you need a little blood, or if you've gotten any kind of medication that happened to go through your vein, that was the answer for IV drug use. So again, it's really important on how you ask the question. We've also looked at hepatitis C. This is looking at 334 people over the course of several years, broken down by Chinese, Korean, South Asian, and Vietnamese. And you can see rates of hepatitis C, similar to the data that Dr. Ward presented this morning. In our cohort, you could see that there's really high rates of hepatitis C in the Vietnamese population. The other thing that I should tell, especially for the students in the room, is I saw that there was a publication from Texas that made it into the American Journal of Public Health, and they had 118 Vietnamese. So we should be in the New England Journal of Medicine with this data right here. So again, you can talk about it, but if you don't publish it, then often it doesn't make any changes. Okay, so what about our community health worker experience? And we thought that I could tell you some quotes from our community health worker. This was from one of our community health workers who worked with the Korean community and said, through individual education, most clients realize how important hepatitis B is. Many of them did not know whether they were immunized or not, thus the clients wanted to have hepatitis B screening. So I think, again, awareness is really key. This is from our a Cambodian community health worker. Most clients are so happy that we provide brochures in our languages, especially the liver in color. It's a brochure that we made. We can show healthy liver, fibrotic liver, cirrhotic liver, and liver cancer. And now this morning we learned that even if you have cirrhosis, depending on how socked in your liver is, and you get adequately treated, this may be reversible, which is really great news. But I think the bottom line is, like I said, talk is cheap, and I think it's a matter of, has all of this work resulted in any change? Now, I have to preface this slide by saying that this is convenient sampling. So we do not have a large enough population to do a randomized controlled trial, but we have been in the same communities for the past 12 to 15 years. And what we have seen is this is broken down into 2-year cohorts between 2001 to 2011. And certainly what we have seen through the work and sort of blood and tears of our community health workers and our community-based model, we have seen a trend downward in those who are surface antigen positive within our same groups. And I think this is really the bottom line. Does the work that you do ultimately make a difference? And I know Mr. Munson was talking about outcomes, and this is one of the outcomes that I think is really, really important to think about. And so what are our next steps for HEP? Again, we are in year 3 or 4. We're in year 4 of 5 of our cooperative agreement with the Centers for Disease Control. Rebecca Cabral, as I mentioned before, is our program officer, and she has been instrumental in helping us pull together a dissemination of our program. We will be launching our dissemination model next year with a bunch of webinars and toolkits and a manual that is coming out, and we hope that everybody can use this to understand best practices for working in Asian communities. A whole bunch of us are going to Beijing together because I think we know that this is a local, global problem. The world is becoming a smaller place, and I think that it's going to be important to be able to talk about what are some of the practices that we've done that have been successful and what can we learn from each other. We are hoping to work with others to look at tracking for immigrants and refugees, because I think this is something that we will talk about in one of our next panels about how do we track these populations and what missed opportunities do we have. And finally, I think it's important that this is not just an Asian American problem. This is a problem that disproportionately affects people of color. Hepatitis C, for instance, when we talk about the yin-yang of chronic viral hepatitis B in Asian Americans, but the other data that I think is important to think about is if you take all African American men over 50, 1 in 7 will have chronic hepatitis C. This is a disease that really disproportionately affects minorities, and if we are not at the table for clinical trials, if we are not at the table for funding, we really won't be able to have any ability to prevent this disease in our populations when we know we have a vaccine that works and we have drugs in the pipeline that are going to make a huge difference. So our hepatitis education and prevention model is a community model that we wanted to share with you, and we hopefully that you can reproduce it in your communities and learn from some of our experiences. Thank you. Any questions? Yes.
In terms of the community lay health advisor model to couple for the each other some disease. But do you think do you have any other next model for that? If you have it, please explain for that.
Yeah, so I mean, I think that what is limited by a community health, community-based screening model is the linkage to care component. And I think that that has consistently been one of the areas that we have worked really hard on. And so I think developing capacity among physicians that can treat, and we are looking at developing a cohort of bilingual, bicultural physicians through some type of educational tool that will allow them to navigate and treat. And we're working with Phung Tran, who is here this morning, who is a primary care physician treating large number of Vietnamese populations. So I think that that has made a big difference. And I think we're looking at models of care that actually have a robust ability for linkage to care programs. I think the problem in Illinois is our safety net program has not been able to accommodate non-speaking Asians, which is a large number of the community members that we see, and the uninsured population in a way that allows sort of a meaningful exchange and a trust exchange because of the paucity of language. And I know that Dr. Demetra was saying that, you know, when an Asian person sees him, their eyes light up because they're hoping that while there's no language communication between a Filipino doctor and a Chinese patient, I think sometimes even having somebody with a face that looks Asian is a very welcoming situation. So we need to build the capacity and infrastructure for more Asian American physicians to treat this patient population.
Okay, just one more thing that I want to make a comment on that. Recently, one of my interests as some health program designer and then the practitioner here, maybe there are some significant model is going on, one of trend. I got a hint from the retail clinic, Walgreens, CVS, Target. So actually, I saw that review that data, and then recently they increased the number of the clinic dramatically. So I mean, there are some market change. Probably they are preparing for the Affordable Care Act, in terms of that. But also at the same time, when you talk about the community health center, maybe it's such as a FQHC, Federally Qualified Health Center, which is the money is maybe 1 million, 2 million, 3 million. But if you think actually it's some different model of the community health center, actually adding some component to the HEP, such as providing the stable routine service and screening to the community by the people who has the key for that each community.
Yeah, I think community health clinics and centers are going to be key for bridging the gap in the Affordable Care Act. And even now, as long as they have full services and have primary care physicians that actually are that are fully engaged in that community health clinic, I think that that's going to be an incredibly important way to close the gap, especially as smaller ethnic practices are going to be squeezed out by health exchanges. I think that is going to be key. And hopefully the infrastructure in terms of support for community health centers will allow that to happen.
Yeah, I mean, actually it's current model. So the application to that part is actually I designed some small clinic hiring the nurse practitioner and then medical assistant in Prospect Heights. So actually we are operating them, we already operate that model. So I think that's one of our efficient, but problem is here is because the physician, the dominant system here. So there are so much limitation in terms of some service by the nurse practitioner and then resident nurse and then some other healthcare provider. So I think so in terms of developing, improving our some program, also maybe our approach should be some figure out that problem because there are not many agencies, community capable of hiring some physician, because of the money issue,
Well, I would just caution and say that, the quality of care is really going to become the driving force. And so while we can close the gap with patching together programs with maybe their volunteer services or non-physician services, which I think physician extenders are becoming increasingly important. I think we don't want to contribute disparities by allowing healthcare delivery to be suboptimal. Not saying that community health, the type of services that you create are suboptimal, but it really needs to be standard of care. It needs to be evidence-based practices. Otherwise, all we're doing is trying to take care of a population by pulling something together that it may not be in the best interest in the long term. So, I mean, I think that we need to be creative, but again, quality of care is going to be driving the dialogue, and we don't want to add disparities, contribute to disparities by making things up because of lack of resources. So we have to think about that in a really careful way.
Oh.
Okay.
Oh, I have one more. Sorry, if I can
Okay.
have one question, please. One opportunity for linking persons into care, at least from my perspective, is always the pregnant woman who is screened and found positive for hepatitis B infection. And we spend a lot of time and effort for good reasons to make sure the infant's properly managed, but it seems to me that oftentimes there's missed opportunities to make sure that mother is referred into care. And I just was wondering what's your perspective on that in the Chicago area about how well that works or not.
Yeah, so I think that, and I would have to ask our community health workers as well, how often are we doing screening events in like sort of third trimester or in pregnant women? Has anybody had sort of a large client base of pregnant women coming in for screening? So I think my sense is that that is a population that is enrolled in care in a different way than what we see for our sort of convenience sample cohort. So either that or they're actually not screened. So I know that if you think about all the pregnant women in the United States who end up passing on hepatitis B to their children, the majority of them, over 50% of them, are still in Asian women. So I actually don't know. I think now with meaningful use and with the Affordable Care Act, screening for third trimester pregnant women is going to be a standard of care, which will be nice. I actually don't know. I have never, in my experience through our screenings, have not really seen any pregnant women as part of our screening event. My guess is that we would be quickly trying to channel them into one of our provider networks.
I just meant, when the obstetrician did the screening, do they refer on to someone who knows how to manage that patient?
Well, so that's a good question. I don't even know how we would track that. So, when the birth immunization, when you did your first immunization before the child left the hospital, that was easier to track. But now that we have that 1 month gap in the multivalent vaccine that you can start at 1 month, my sense is, and I have not seen this data, is that there was a decrease in uptake among this population, but I'm not sure. Okay, thank you so much.